Good morning. My name's Elliott Taylor. I'm a research fellow based at the International Centre for Eye Health at the London School of Hygiene and Tropical Medicine. And today I'm presenting data on the prevalence and risk factors associated with corneal opacity in the Gambia National Eye Survey from 2019.
Sorry, is it? I think they can't hear it. Wait, is
for the talk.
Corneal opacity is a common cause of blindness and vision impairment globally. A recent meta-analysis estimated that 5.5 million people have bilateral blindness, and an additional 6.2 million people have unilateral blindness due to corneal opacity. Over recent decades, there's been a shift in the pattern of corneal disease worldwide. Previously, trachoma, onchocerciasis, leprosy, ophthalmia neonatorum, and xerophthalmia were considered to be the major causes of corneal opacity. Public health initiatives have been implemented to combat these conditions, leading to a reduction in their prevalence and associated vision impairment. These have likely now been overtaken by infection and trauma as the leading causes of cornea-related vision impairment and blindness. The Gambia is a small country in West Africa with a population of around 2.8 million people. The first National Eye Health Survey in the Gambia was conducted in 1986, with a follow-up survey in 1996 after the establishment of a National Eye Care Programme. During that 10-year period, the crude prevalence of blindness fell with a relative reduction of 40%. An 80% relative reduction of blindness from trachomatous corneal opacity was also observed. In contrast, however, the estimated number of individuals blind due to non-trachomatous corneal opacity increased over the same 10-year period, and that formed the second leading cause of blindness in the 1996 survey. The National Eye Health Survey was then repeated in 2019. This analysis aimed to provide an update on the prevalence of corneal opacity
And to also identify risk factors associated with corneal opacity in the Gambia.
This was a cross-sectional, nationally representative survey conducted among adults aged 35 years or older using multi-stage stratified cluster random sampling. Monocular distance visual acuity was measured using peak acuity, and slit lamp examination of the eyelids and anterior segment were performed by ophthalmologists. Corneal opacity was classified using a previously described grading system, which I'll come on to later. Counts and prevalence estimates were adjusted to correct for age-sex imbalance in the surveyed population compared to the national census data. Corneal opacity prevalence was estimated, and associated risk factors were identified using multivariable logistic regression. So out of 9,188 participants, that was with a response rate of about 83%, 878 had corneal opacity in either one or both eyes. This gives an age-sex adjusted prevalence of almost 10%. We found that corneal opacity was more likely to affect one compared to both eyes. 41% of eyes affected by corneal opacity were found to have moderate or severe vision impairment or blindness. And there was a strong correlation between visual acuity and corneal opacity grade.
As the severity of corneal opacity increased,
Vision deteriorated. And this is demonstrated by the box plot here, which has corneal opacity grade on the x-axis and logMAR visual acuity on the y-axis. You can see there's a general trend of reduced acuity from corneal opacity grade C1, that's the second box, to C2D, and then a sudden drop in visual acuity between C2D and C3. As I mentioned, multivariable logistic regression
was used, and this identified
trachomatous trichiasis, older age, rural residents, and male sex as risk factors independently associated with corneal opacity. So in terms of the lessons, the study used a previously described corneal opacity grading system, where C0 was no corneal opacity, C1 is an opacity outside the central 4 millimeters of the cornea, C2A is an opacity within the central 4 millimeters of the cornea with a visible pupil margin, and C2B is the same, so within the central 4 millimeters of the cornea, but without a visible pupil margin. C2C is an opacity within the central 4 millimeters of the cornea, with a visible pupil margin, and C2D is an opacity again within the central 4 millimeters of the cornea, but without a visible pupil margin. And C3 is an opacity involving all of the central 4 millimeters of the cornea without a visible pupil margin, and C4 is physis. So grading corneal opacity can be challenging in epidemiological surveys, as its appearance
varies with changes in illumination and lighting.
So to ensure consistency, the survey team endeavored to make examination settings as standardized as possible and use a grading system that categorizes corneal opacity both by location and by density. And this showed a strong correlation with the degree of visual acuity in the affected eye. Another challenge is determining the cause of corneal opacity retrospectively in epidemiological surveys. Attempts can be made to do this based on clinical history, although this may be unreliable. And so we therefore didn't actually attempt to determine the cause of corneal opacity in this particular survey. The prevalence of corneal opacity in the Gambia remains high at 10%, and so further research is needed to better define the epidemiology of corneal opacity in the Gambia, to then inform public health programs to address the ongoing burden of corneal disease. Thank you very much for your time.
Questions? You're on it?
Yes. Thank you.
It's a wonderful study. In fact, a lot of learnings are there. And it's very high prevalence in Gambia also for corneal opacity.
In India, you also did this survey, National Corneal Blindness Survey. And we also get that region is also important cause, though it is not central corneal opacity. But this is one of the leading cause of corneal opacity. Would you find such cases in your study also?
Yes. So though we didn't determine the cause of corneal scars, we did identify and examine for pterygium, and the prevalence of pterygium was found to be particularly high in this survey as well. Hey, one question, Bodivus.
Yes. Say these things.
No. So if you look at how many trauma and the sketches other causes, you look at how many was post-cataract surgery, corneal opacity, let's say. No, so with the corneal scars, we did actually, because eyes have your cataract surgery. So it's how many people that can. Yeah, so we could actually look at that data. We haven't analyzed that data as part of this analysis, but we could actually go back and look at what I think the one in India also like post-cataract surgery, upon recipe one medium cause. You could be safe kind of thing from other part of me. So I think really better on the unilateral and visually impairment unilateral and Bharati virus. Yes, we've got that data. I'm presented today, but we're hoping to publish this paper quite soon, so that will have the data through that. That question is I could here put as a C4 category. I just can do the partner and go patent petitions. Only might be partner I won't go. Yes, that's a very good question. We didn't actually have too many case bisons but we weren't actually able to go back and differentiate causing physis within those participants who are identifying something bisons in the survey. So that's definitely one of the limitations. I think Professor Brothers put a stat to that, but the reason we back biases this goes to aligning with the trachoma details of code Greek scale, which has biases pot grade. So it were able to relate back to that.
Thank you very much.